Hello, everyone. My name is Erin South, and I would like to welcome you to the Office of Women's Health Scientific Speaker Series, PCOS Revisited, Diagnosis, Management, and Future Needs. Before we introduce our speaker, I have a few announcements regarding continuing education credit for this activity. All speakers are expected to use generic names. If trade names are used, those of several companies should be used rather than that of a single company. Speakers attest that the content they contribute is supported by the best available knowledge or evidence and are reminded to disclose when products or procedures being discussed are off-label, unlabeled, or not FDA approved, and any limitations on the information that is presented. This activity may reference off-label use of FDA-approved products. Our speaker has the following relationship to disclose: May Health DSMB member of clinical trial. Our planning committee and CE team report nothing to disclose. All of the relevant financial relationships listed for these individuals have been mitigated. The views expressed are those of the speaker and do not necessarily reflect official policy of the US FDA. No official endorsement by the Office of Women's Health or US FDA is intended or should be inferred. Questions related to CE credit claiming should be directed to Rachel Buetta. All other inquiries for information should be directed to me, Erin South. All registered participants will receive a CE claiming code and instructions by email within 24 hours after the seminar. To claim CE credit, all physicians, pharmacists, nurses, and those claiming non-physician CME must attest to their attendance and complete the final activity evaluation via the CE portal within 2 weeks after the activity, no exceptions. Learners may then view and print a statement of credit. Pharmacists and pharmacy technicians will need to enter their correct NABP e-profile ID number and date of birth in the required format. Failure to do so may result in loss of credit for the activity. Pharmacists should log into the CPE monitor 8 weeks after the activity to ensure their credit is captured correctly. Closed captioning is available by toggling the button at the bottom of the screen. Throughout the presentation, you may type your questions for our speaker into the Q&A box, and we will address as many as time allows. And now, please welcome our OWH Director and Associate Commissioner for Women's Health, Dr. Kavita Vasisht.
Thank you so much, Dr. South, and thank you everyone for joining us today. Happy National Women's Health Week. Our theme for this year is Know More, about your health today and every day. And this week, we're bringing attention to a range of health topics that are specific to females, such as polycystic ovary syndrome. And we're thrilled to have Dr. Hoger here today. She is a professor of obstetrics and gynecology and the chief of the Division of Reproductive Endocrinology at the University of Rochester. She's a board-certified reproductive endocrinologist and completed a master's degree in public health with an emphasis in clinical investigation. She has a research interest in the management of polycystic ovary syndrome. This work has led to the establishment of the PCOS Lifestyle Center at the University of Rochester, for which she is currently serving as the director, focusing on nutrition, lifestyle change, and medication in the management of PCOS. She is also an active clinical investigator and serves on the board of the AEPCOS Society and maintains an active clinical practice in reproductive endocrinology. I'd also like to invite our viewers to read our Office of Women's Health blog for National Women's Health Week, which features a Q&A with Dr. Hoger and is focused on PCOS. And I'd also like to thank my team in the Office of Women's Health for bringing today's seminar to you, the blog, and all of our other National Women's Health Week events. Dr. Hoger, thank you for being our speaker, and we are very much looking forward to your talk today.
Thank you very much. And I want to extend my appreciation for the invitation and to Dr. South, who's been working with me to get this ready. So it is really a pleasure and an honor to be talking to you in women's health and obviously about this very important area. So I think from the standpoint of the disclosures, we are already covered those, so I will move on to our objectives for this talk. So we want to understand the impact of PCOS really across the lifespan, discuss the options for management of PCOS at the different life stages and varying needs, and recognize our limitations and gaps that are available in treatments for PCOS. So I'm going to go back to when I first became a reproductive endocrinologist, the only criteria for diagnosis was the NIH criteria. So they were originally put forth in 1992, and there was basically two features. You had to have some form of irregular periods with oligo or anovulation, and some evidence of clinical or biochemical hyperandrogenism after all the other endocrine assessments had been completed. And then as technology improved and we recognized that this disease is not a single entity, but rather traverses a spectrum of different presentations. And with the introduction of ultrasound as a very formal part of our evaluation, the Rotterdam criteria in 2003, so now 20 years old, came up with 3 criteria. And the idea was that it gives a little more flexibility to the diagnosis. And now that Rotterdam criteria, which adds the PCOS imaging as an option, will allow a better and broader diagnostic criteria and is accepted by all the major endocrine societies across the world. So the clinical features, PCOS came from a reproductive history. So as an OBGYN, obviously this is fundamental to sort of how we look at the world through our reproductive lenses, but we recognize the disease is more than a reproductive disease. Even though the definition comes from its reproductive impact, the metabolic and psychological factors that we now recognize to be intrinsic and fundamental underpinning of the disease itself have been recognized. In fact, there is a push to rename the syndrome because it doesn't necessarily encompass all of the other aspects. But important for us as educators and clinicians to recognize that this is a disease that goes beyond the reproductive arena. So the lifespan of PCOS is really the same as all of the diseases that we talk about that cover from adolescence to older age. And while the reproductive disorders often are what bring people to attention. So in adolescence, when I see adolescents, it's because of their menstrual disorders or their concerns about androgen excess. As we care for women across their lifespan, the other complications become more prominent as they age. So first into pregnancy complications, and then issues of type 2 diabetes and cardiovascular risk become more prominent, and the reproductive issues become less so. So in our multidisciplinary approach, even though, endocrinology and gynecology sits in the middle, we are constantly looking at other specialties to assist. So I work with pediatricians, dermatologists, endocrinologists, diabetes doctors, and cardiology folks to really care for women. So it is really a multidisciplinary approach that's required for the total care in PCOS. And we care about PCOS, and we'll talk a lot about the prevalence. It's a very prevalent condition, and the health and economic burden from this disorder is quite high. Recent publications have indicated this is a really leading issue in women's health. There's links to the rising burden of obesity that affects a lot of diseases, but also particularly PCOS. And for many years, this has been under-recognized as a disorder. There's long delays in diagnosis. Women often suffer for a long time before someone gives them a diagnosis. Their diagnostic experience is often very unhappy. Their emotional well-being is underappreciated, and we don't recognize the metabolic risks well. And that leads to inadequate patient information, and the ability to sort of intervene with lifestyle management somewhat limited. So there's a lot of pressure for us to get this out there in the education sphere. So the prevalence, as I alluded to, so when we went back to 1992, and I said those were the first criteria that were formalized so that we could help make a diagnosis. If we use only those criteria, we have a relatively low prevalence, although still fairly significant. But now with a systematic review using Rotterdam criteria and all of the population-based studies, we're somewhere between around 10% to maybe 15% overall in the population, which is an enormous burden of disease. We know that in health professional worlds, our management is not consistent among specialties, and we make it a high priority for education now amongst our health professionals. And evidence-based guidelines are really what we were aiming for. So we, in 2017, led by the Monash Group in Australia, a multidisciplinary collaborative approach was started to begin trying to pull all the evidence together to make guidelines. And I was fortunate enough to sit on this international committee, and we were able to sort of synthesize quite a bit of data, and I'll share the current guidelines with you. So we began with stakeholder participants. So this was the researchers, the clinicians, the patients, the consumers, with framing the problem and trying to identify what are the priorities for the group. Then there was knowledge synthesis, systematic review, international guidelines were put forth for public review and amendment, and then resource development, translational activities, as well as co-developed international awareness campaigns and evaluation. So after about, I guess now 5 years of going through this cycle, we restarted the stakeholder participant and have updated the guidelines for 2023. So they have now gone through the process and are going to be published this summer, but they are officially through the stakeholder assessments. And again, it's a collaborative approach. We want to drive early diagnosis, screening, and management across the life span. We want to optimize the health resources and reduce unnecessary tests so people are not getting repeatedly done the same tests. We want to have translational tools and resources for patients and providers. And we want to promote research and translation into practice and policy. And finally, we want to upskill and empower consumers so that they know what their options are and can advocate for themselves. And we all talk about evidence-based practice in medicine. As an academic physician, this is sort of our lifeblood, right? Evidence-based practice. What does that really mean? So it's not simply just taking a randomized controlled trial and saying, okay, there's the answer, everybody gets X for their treatment, because it's really looking at the wheels of the consumer needs and preferences and clinical judgment that we have based on our own experiences, integrating all of these and coming up with a treatment plan that is evidence-based, but also consistent with patient values. So the first thing we have to do with PCOS is diagnose it. It seems like that should be simple, but in reality, this is probably one of the most difficult areas. It took a long time to get people to agree how to diagnose it, and we still don't have a perfect diagnostic system, which we'll talk a little bit about later. But because we have the 3 pillars, we have androgens, irregular cycles, and ovarian findings, we can sort of focus our topic on what is the best way to measure hyperandrogenism. What is the best clinical way? What is the best biochemical way? And the key messages that came out of our investigation were that clinical hyperandrogenism is the first thing. So the person complaining of what she perceives as hyperandrogenism is the person we look at and assess on a physical basis. And we use validated tools for that, using the distress index as a primary concern, recognizing there are going to be a lot of ethnic differences in how people present. And if we are unable to sort of clarify that, using biochemical measures can be supportive. The real concern with biochemical measures, there's a lot of variability in how the assays are done. And all of the data now really formally recommend the liquid chromatography mass spec for measuring androgens, because these are relatively low levels in women compared to men. And so we know that we want a very specific and high quality assay to really be able to differentiate at the lower levels. So when I mentioned a visual scale, we have traditionally used the Fairman-Galway score. There really aren't very many scores. This is not a perfect measure. It's been modified from its original way back. It was based in a single population of people, so it doesn't have a lot of scaling to ethnic differences. However, a 0 in any of the body areas would indicate there's no androgen exposure. Androgen exposure in areas where there are receptors can turn hair from vellus, which is sort of a peach fuzz, to a darker hair. And the darker hair is an androgenic hair. And as we get more androgens, those areas progress. And so we can put a number to this, and we can measure it, and we can follow it. And then the other thing that's particularly distressing, and one of the things that is probably underappreciated, is that androgen excess can also lead to hair loss from the scalp. And that can also be measured on a visual scale as well. This is a very distressing component of PCOS, and we do not generally use that in the diagnostic criteria, but just to be aware, there are visual scales. Now, the hard part of all of this is the normative cutoffs. So when we say that something is abnormal, compared to what, right? So we have to think about most of our abnormals are, okay, if you've got 100% and the top 5% is abnormal, that's really sort of random. It's not really based on any biology. That could vary by ethnicity and by age, which we know reproductive hormones definitely do that. So the idea is we've moved to cluster analysis to try to accurately define the natural distribution of these hormones in a population and try to classify people into different groups that are based on these profiles and correlated features. So we're still in the infancy really of looking at this, but I want to bring forth one study that's applied to an adolescent population. It's in press, should be published soon. This is a adolescent population with a mean age of 15 years. This is a non-specialized group. So this is community-based participation of adolescents, and they all underwent an exam, an ultrasound, and blood testing. There was a hyperandrogenic cluster that they defined by looking at the population and picking a number somewhat randomly and saying, okay, these features indicate the hyperandrogenism. And then they looked at the other aspects that weren't part of the cluster to find cutoffs for those values. And when they did that, they found a higher AMH in the population that was listed as hyperandrogenic. They found lower SHBG and higher BMI and higher total testosterone. So it really did correlate with actual disease process that they found. And what was interesting in this population is when they looked at where did those cut points indicate, they found they were not 95th percentile, but in fact were lower around 70th percentile. So when they do this kind of analysis, we're going to get more accurate numbers. It's not going to be just a simple percentage situation. So with respect to irregular cycles, it seems like that would be pretty easy to define. But in adolescence, again, we find that there is a difficulty because what happens over the period of puberty is that in the first year post-menarche, over 80% of cycles are going to be anovulatory, which means they're not going to be as predictable. There's going to be a high degree of irregularity, and none of that is abnormal. So you wouldn't want to take a 12-year-old and say, okay, you have irregular cycles, you have PCOS, because that would be inaccurate. And when we get to 3 years post-menarche, we still see about 50-50 that some cycles are anovulatory still. So somewhere between 1 and 3 years, most people are starting to regulate and become ovulatory. And by the time you get to the 6th post-menarchal year, you have the majority of people with regular ovulatory cycles, and that 20% remaining, that's where the pathology lies in terms of it not being normal. And if we look at what kinds of cycles these individuals have as adolescents, the majority are going to have very long cycles. So they're not going to have, sort of cycles that fall in between, but they're going to have either very short cycles or very long cycles. And so we're going to find a particular pattern to define irregularity. So again, when we're looking at irregular cycles, we have to say in the first year post-menarche, we are not going to make a determination. We are not going to make a diagnosis. Between the first year and the third year, we're going to have a tendency to have very long cycles or very short cycles. And in those individuals, we can start to classify them as abnormal. And then once we get past the third menarchal year, we now have into adulthood, we have less than 21 days being abnormal or greater than 35 days, because the majority of people are going to fall that are normal are going to fall between there. Or we can define it as less than 8 cycles per year when you calculate that out. Because even in PCOS, you're going to have some cycles that may be ovulatory and normal, and then they may stretch out. So we look at the total number or the average number of days. But within that, if someone is past a year post-menarche and they have very, very long cycles, more than 3 months, that's clearly abnormal. That's outside the normal range. If they never have periods by the age of 15 or by 3 years after they have breast development, that's clearly abnormal. And when you have irregular menstrual cycles, you should consider the diagnosis of PCOS according to those guidelines. So that's it is probably the most common cause of irregular cycles. Obviously, there are other things that can cause it, but this is going to be one of your primary diagnoses, should be popped right up there in your diagnostic criteria. And the third pillar, so we went through androgens, we went through is cycles. The third pillar is the ultrasound that was added at the Rotterdam criteria. So now it becomes a question of when is ultrasound indicated and what is the most effective criteria that we use. For those of you used to seeing ultrasound, you're going to notice this right away. This is not a normal ovary. This is a larger ovary. There's a large number of these very small 2 to 9 millimeter follicles. In this case, they're lined up around the periphery, which is a fairly classic pattern. They don't have to be, but the key is the size of the ovary and the number of follicles that you see. So the recommendations that have come out of the guideline based on evidence, and I'm going to just clarify here. So what you see here, evidence-based recommendation is identified as EBR. These are clinical recommendations identified as CR. And then there's a third thing that will say practice point as a PP. I've tried to box the evidence base. So as we go through the presentation, if you see this box, that's generally the evidence base. And sometimes there are important things below that I'll box as well. So the evidence tells us what we should count as abnormal is the follicle number per ovary. So we count out those little antral follicles, and that's the number we use. And that's how we identify PCOM. If we have a three-dimensional view, we're going to count all of them, but you can use a single slice, just like we saw in the last slide. And we're going to look at the follicle number in that cross section and the ovarian volume combined. So ovarian volume greater than 10 cc's and follicle number greater than or equal to 20 antral follicles would be consistent with a PCO ovary. Now, this is based on transvaginal ultrasound, and of course, in adolescence, that's problematic. So unfortunately, there are no definitive criteria to define PCOM in adolescence. We don't have a lot of evidence on this. There are very few studies, so these are really practice points. But if you happen to do an ultrasound, it's likely to be transabdominal, and then we're just going to be able to look at the volume and not so much the criteria of the morphology. Now, in the current guidelines, that's where the old guidelines cut off, because we have now a tool, anti-Mullerian hormone, or AMH, has been around for several years as a diagnostic tool for other conditions. But what we've noted in PCOS is everyone who takes care of them, if you measure an AMH, it's like off the charts. So why can't we use that as a diagnostic tool? Well, up until recently, we didn't really have the data to tell us that that could be helpful. But to remind those of you who are not familiar, AMH is a product of the early antral follicles. So from when they're morphing from primary follicles to preantral follicles, they secrete AMH. And so AMH is a measure of those follicles that are coming before we can physically see them on ultrasound. FSH will stop the production of FSH, but will cause the development of the larger antral follicles, which no longer produce the AMH. So it comes in that window where it's very important to sort of say, we can see there's pathology there because there's a lot of follicles. And in PCOS, as we said, they have high levels of AMH. Now, in a non-PCOS follicle, so this represents a follicle, FSH binds to the receptor, produces a switch to estrogen production over androgen production, which then turns off the AMH production in that follicle so that it grows and becomes an ovulatory follicle. AMH isn't really playing a role in the pathology. But with PCOS, we think not only is it a marker, but it may have some pathology involved inside the ovary. So as it goes, it's much higher. So it's turning off that estrogen production, and it's not allowing that follicle to go from an androgen-producing follicle to an estrogen-producing follicle, and you get this follicular arrest. And that follicular arrest is why we see a piling up of all those antral follicles. So the ultrasound image is really reflecting what we're seeing in the biochemistry with AMH. And the data are now very, very clear that we can use AMH for assessing the antral follicle excess instead of using an ultrasound, because ultrasound is not available everywhere. In certain communities, that's not, whereas in my office, I do 100 ultrasounds a week. That's not clear in every other practice. AMH should be used in accordance with the diagnostic algorithm, noting that people still have the assessments of the irregular cycles and the hyperandrogenism, and you don't need an AMH to have the diagnosis. So you don't have to order it. It's really not a single test. You don't want to say, okay, AMH, yes or no. It's not meant to be a single test. It's just like the idea of the ultrasound, using it in conjunction. And we do not have normative values for AMH in adolescents because AMH is going to be higher because their follicle counts as a whole are higher. And we have to remember that AMH is influenced by a lot of things. So age, someone 40 is different than someone 20. BMI, AMH is lower as BMI goes up. Serum AMH may be influenced by the ethnicity of the individual. Birth control pills will suppress it. Menstrual cycle may vary it. So those are things to keep in mind. So the pillars of the diagnosis are now, I think, pretty clear from the document, the guidelines. We have a good way to describe androgens. We have a good way to describe periods. And now we have two tools to look at the ovary, either AMH or ultrasound. So once you have the diagnosis, again, going back to our original discussion, PCOS is not just a reproductive disease, even though that may be the presentation that the individual has. There are lifelong consequences, and how do we diagnose and manage those is the second tier, the second part of our discussion. And just to kind of summarize, we are not going to talk about genetics in this talk, but I will advise you there are several very well done GWAS replicated studies from many different populations, both in Asia, North America, Europe, that have indicated there are clear pathways to genetic abnormalities. It's linked often with overlap with obesity genes as well as diabetes genes, but there is a pathway that genetics is playing, a very prominent one. 50% of daughters of women with PCOS will have PCOS, 50% of sisters will have it. So it is a very trackable genetic condition. But equally important is the lifestyle component. And they are both playing a role in the development of PCOS, including antenatally as the individual is developing in utero. So there are hormonal changes that are affecting the ovary in the individual. If we layer on obesity on top of that, we are getting even more exacerbations. So you have the leading component leading to that excess androgens that's resulting in our reproductive phenotype. But when we look at the lifestyle issues and obesity, you were talking about insulin resistance, which is now felt to be sort of the major underpinning of the pathophysiology, not part of the diagnosis, but part of the pathophysiology. Increased insulin resistance leads to increase in diabetes, cardiovascular risk, and then of course, underpinning it all is the psychosocial issues. And we believe that those are being driven to a large degree by the insulin resistance component. So the first question we had at the guidelines is, are women with PCOS at increased risk for cardiovascular disease, and what is the most effective method to assess it? And the evidence really is pretty clear about risk for cardiovascular disease. What it is not clear about is cardiovascular mortality. So their data are still a little uncertain as to whether women with PCOS have an increased risk of dying from cardiovascular disease, but they definitely have an increased morbidity, and they have all the risk factors that we would associate with that. So we would like health professionals to be aware that all women should be assessed for this. So that is including any age and BMI. So lipid profiles would be indicated, as well as blood pressure measurements. So these are things that we think are fundamental as you're taking care of women with PCOS to at least get at the baseline. And we think that because of this recognition, funding bodies should recognize that PCOS is highly prevalent with multi-system effects and should increase research to support that. Because one of the major findings of all of this is that it's very under-researched, underfunded compared to other diseases that are much less common from NIH funding, for instance. Cardiovascular general population guidelines should include PCOS as a risk factor. And we would want to have preventive strategies to reduce cardiovascular risk, sort of talking about that in conjunction with the reproductive risks that we talk about as well. And then when it gets to type 2 diabetes, this is actually pretty well known because, again, going back to the beginning, this was one of the links that was found very early in the research of PCOS. But PCOS, regardless of age or BMI, women do have an increased risk of impaired fasting glucose, impaired glucose tolerance, and type 2 diabetes. You see this quite often every day in the clinic. I'm diagnosing diabetes. I am not a diabetologist. I'm a reproductive endocrinologist, but it's because I'm seeing women with PCOS, even in young ages, that we're seeing a high prevalence of this. And so glycemic status should be assessed at diagnosis in both adolescents and adults. How do we do that? So we have an algorithm now that I think is helpful. We want to assess weight and BMI at each visit, or at least, month or 6 months or yearly. And it's a coordinated and agreed to between the health professional and the individual, because we'll talk a little bit about weight stigma down the road. But glucose screening should be a part of every initial assessment and at least every 3 years. If someone does not have any other risk factors for diabetes, we do an A1C or a fasting glucose. If there are other diabetes risk factors, and most of that is yes, in our PCOS population, either family history or obesity, then we do an oral glucose challenge test. And certainly in preconception planning and early in pregnancy, it is recommended. We would recommend blood pressure checks on an annual basis because there is evidence of increased hypertension in this population. And then lipid screening generally is recommended based on risk. Obstructive sleep apnea should be considered. We find that at a very high rate in PCOS, and treated if symptomatic. And then with respect to endometrial cancer, this is something that's often overlooked by our non-gynecologic colleagues, and it is an important component. Premenopausal women with PCOS do have a much higher risk of this. I think I have had personally several young women in their 20s who have developed endometrial cancer. Particularly because they're being untreated. So they have, even though they're 22, they might have had 10 years of not having their menstrual problems assessed or treated. They have higher weight and they may develop early diabetes. So if those are conditions you see, we want to make sure that we are assessing the endometrial cancer risk as well. Then obesity. I would say of all the things that we see, the main reason that people are driven to come into my PCOS clinic is they're concerned about weight and its trajectory in PCOS. This is a very common concern. Right now, the data do not tell us there is a consistent evidence that links a certain type of physiology to weight in PCOS. However, even though we don't understand those mechanisms based on evidence, it is well recognized that most, if not all, women with PCOS have underlying mechanisms that drive greater longitudinal weight gain and higher BMI. So these kinds of mechanisms are making it harder to manage weight, greater challenges. Healthy lifestyle is important, and the prevention of excess weight gain should be addressed at the early onset. And we should be prepared to assist women in forming realistic and tailored lifestyle goals. Weight stigma, I mentioned that earlier. So weight stigma is something that basically indicates that that individual is seen first for her weight and second for her condition. And that is very problematic in terms of helping individuals, because weight doesn't explain all the pathology of PCOS. It does improve if you lose weight to a large degree, but it is not the only concern. And I think it has very negative psychosocial impact if we don't recognize that bias as we're caring for people. So what does it mean to recognize it? Is that we have acceptance and respect for the body size of the people who present to us. That includes saying that while it's a risk factor, it's only one indicator of health. We should ask permission about weight, recognizing some of the terms we use and we continue to use because it's part of our literature, may be stigmatizing, and just try to be careful with that. We want to ensure we have appropriate equipment, offering weight-centric care for those that want to lose weight, or weight-inclusive care if people are not ready to have that discussion. And then focusing on quality of life. So quality of life is a constellation of things, but in PCOS, the things that we know to be out of sorts are anxiety and depression, which we'll talk about, but also poor body image, psychosocial dysfunction, and eating disorders, all of which are more common in women with PCOS. But anxiety and depression is particularly underappreciated in this population. So this is a systematic review that was done, and we looked at this again. There was really been no updates to it, so I think it still holds that the overall population of PCOS versus women without PCOS, there's more than double the rate of depression that we see. And if we look at the degree of depression, it's much more likely to be moderate or severe. So this is clearly something of concern. The same is true with anxiety as far as prevalence. It's quite a bit higher in women with PCOS. Anxiety is one of the more common traits that we see. It's very dramatic. It's even seen in animal populations with PCOS when they induce a prenatal androgenized mouse and they put it in a in a maze, it will never go out in the open because it has such high anxiety. So we think it's one of these things that does have some fundamental pathology from the outset. And when we look at who's more likely to have continued depression and PCOS, this data comes to us from the University of California, San Francisco in their multidisciplinary PCOS clinic. They measured the findings at 29 years of age and 7 years later, and they had a very high prevalence, not surprising, as we just said, of depression. And it was very consistent over the 7 years, but there was a variability. Some women treated for depression got better, others did not. And so the predictors for the long-term depression risk was really driven by BMI. So every time BMI increased, it increased the risk of an enduring depression. So there's a very tight link between obesity and depression. There's also a metabolic link. So we see abnormal metabolic parameters also predicting higher rates of diabetes. And then when we look at the impact of race and on anxiety and depression, we do see some differences between the races in the US. We see higher anxiety in white women compared to Black women, and perhaps a trend towards higher rates of depression in Black women. And taking this from the consumer perspective, so this was a very important part of our work in the international guidelines, is having the consumer perspective on every single committee, and they presented from all over the world. So this is the president of the PCOS Association of Australia, and she said that PCOS is very distressing to women who are living with the condition and presents differently from person to person. There's no one treatment or medication that treats PCOS holistically, and there's a lot of frustration with the lack of headway in PCOS-specific treatments. And this is the message we're getting over and over from the consumer, is that we don't have any treatments that are specifically designed for PCOS. There's a lot of dissatisfaction, how slow it takes to get diagnosis and what kind of care there is. So we still have a long way to go. So the key points in treatment planning is that you need to tailor the treatment. Lifestyle, we think, is critical for everyone because of the pathophysiology of insulin resistance, which lifestyle can address. But we also need to target therapy for the primary concern. If patients want to get pregnant, if they have concerns about their menstrual cycles, if their hair growth is distressing. And we also want to look at a chronic illness and what is the long-term treatment and what pharmacotherapy do we have. So this is what I would consider some of the ideal workflow of the multidisciplinary clinic, which I mentioned at the beginning. We started at our clinic in University of Rochester. There are many around the country that do this. We have a team approach. So we have the provider, nutritionist, behavioral health, nursing support, including the patient on the team. And then we have outside discipline specialists like dermatologists, GI, and endocrine to sort of complement. Prior to the appointment, we bring in patient engagement. So they bring their goals on a screening form. We provide assessment, including blood work and ultrasound that they've had before. So we can look at that and assess whether they need to do it again. We screen everyone for depression and anxiety and whether they're ready to have that conversation. At their first visit, we do the multidisciplinary intakes. We order additional assessments, and then we come together as a team and set the treatment plan. And then follow-ups are based on progress on those goals we set at the first visit, and we make adjustments as we go. Sometimes people come in because they're worried about their periods, but then 2 years later, they want to get pregnant. So we have to adjust kind of what we're doing. But fundamentally, as I said, we're looking at lifestyle. So lifestyle intervention, which is defined as either exercise alone or a multi-component diet combined with exercise and behavior strategy, is really recommended for all women to improve metabolic health, including central adiposity and lipid profile. And these data have shown over and over that lifestyle will improve those things in PCOS. It should be recommended that they all try to optimize general health. It will improve quality of life and body composition. But at minimum, maintaining weight and preventing weight gain should be part of the discussion. There's no evidence that there's one type of diet that is better than another. I think that's probably the most common question we get at the lifestyle clinic. Okay, should I be on a low carb? Should I be gluten-free? Should I? And there is no evidence. So whatever diet that is considered a balanced and healthy diet that works for that individual has been tried probably in some study and has benefited the patient. So we know that there is no one diet. Anyone that says that is probably trying to sell you something. It is not appropriate to say that's the only way. But each person needs support for the decisions and choices that they're making. We consider lifestyle change to be first-line therapy. Healthy lifestyle for excess weight gain prevention is really important, even if they're normal weight. So I see a lot of normal weight women with PCOS. We talk about how to prevent weight gain. We want to aim for 5 to 10% weight loss over a 6-month period if they indicate they wish to lose weight. Energy deficits around 30%. Exercise we don't prescribe in a specific way. The data are not enough to tell us there's a specific exercise that's better, but not being sedentary, which is true for all of us, as I've been sitting here all morning. We need to move in 10-minute intervals. And we want to try to have realistic, specific, measurable goals that we can follow with the patient. But in addition to lifestyle, there are going to be needs for pharmacologic therapy. And we're going to talk about the main ones here, which are the birth control pill and metformin and some of the others that we can add in. So the medication options, as we've been saying all along, we need to address medications to the condition the person is concerned about. So if you are coming in with irregular cycles or hirsutism, the treatment of first-line therapy is the combined oral contraceptive. That will address both of those very well. Many people don't want to be on birth control pills or they don't tolerate them, so there's need for other treatments, but that is still tried and true going to be fundamental to most young women who are concerned about PCOS. And there are, people can try anti-androgen therapy or progestin therapy as well. There's not as much data on that alone. Those that continue to have worsening hair growth, we do have data on anti-androgen therapies that are listed there. It is not something that we start with generally in most people and don't treat a majority of people with that. And metformin therapy, which is obviously used for type 2 diabetes, but off-label, we use it because of insulin resistance and glucose intolerance, and we do see improvement there. And then more recently, there's a big push on weight loss drugs. These do actually work very well in the PCOS sphere. Again, at this point, still a little early to say what the impact on the disease is, but they certainly are very effective for weight loss. So I want to bring your attention to a study that was completed out of the University of Pennsylvania. And what they did was they randomly assigned people to either an oral contraceptive or lifestyle intervention. This was an NIH-funded study. And what they looked at was after 4 months of treatment with either a birth control pill or lifestyle, in both groups, they saw a reduction in the rate of depression, which I think is very telling because a lot of times people say, oh, the birth control pill, I don't want to get depressed because I take it. In general, this is not the finding we see in PCOS. And as well with anxiety symptoms, they both improve the rates of anxiety. So reducing androgens, regular cycles, either through lifestyle birth control pill does seem to address some of those issues as well. And with any pharmacologic therapy, it's going to be shared decision-making. And you need to talk with the patient, their family, if there's adolescents involved, what their cultural values are. We need to understand those before we can make a recommendation. But we generally don't want to sort of say there's only one way to go, and recognizing, as we've said, it's all off-label. We don't have a specific pill for PCOS, but we need to inform people about the side effects and the concerns. And we do think that eventually we would like regulatory agencies like the FDA to consider some treatments that are specific for PCOS. Now, the evidence bar here is really big because everything about birth control pills has been well documented in PCOS. There's good evidence that it should be recommended as first-line agent to control menstrual cycles. It's very helpful in adolescents. One point we would make is that it does not need to be a high-dose birth control pill. It can be any dose of estrogen in the pill that can be effective. There's not a specific pill type that one needs to be on. That's common misconception that there's only one type of pill. That is simply not the case in any of the literature. There's not any real evidence on the progestin-only pills in PCOS, but it does have in the general population benefit for endometrial protection. And so those are all evidence-based recommendations. And finally, I'm going to talk about metformin because this is really, I go back to this partly because when I was a young fellow, I was starting my fellowship, and right that very year, a little paper came out about using metformin for PCOS. It was just a small little case series. And at that point, the data were just coming out saying that there was a connection between insulin resistance and diabetes and PCOS. So somebody in South America actually tried this. And I was in Virginia at the time, and there was a group at Medical College of Virginia as well that decided to try this. And it became really a hot commodity, and everybody wanted to study it. So this was my first research in PCOS, was looking at the impact of metformin, lifestyle, and birth control pills in adolescent women with PCOS. So over the 20 plus years since that original interest in metformin, we now have quite a bit of data. And we can see that BMI is impacted when you give metformin, but it's not a huge impact. You can see the red box there. It's a small impact, but it does have an impact on BMI. And when we look at androgens, there is an impact on testosterone. All of the studies indicate, but it's not very powerful, to be honest. So the recommendations that metformin should be considered in women with PCOS with a BMI greater than 25, because it does improve insulin resistance, glucose, lipid profiles, and androgens. You can consider it in adolescents at risk for PCOS as well, because there's good data in early data anyway in adolescents. And if we compare the birth control pill to metformin, we can see with respect to testosterone. So to the left is OCP favored, to the right is metformin favored. And if you look at the red box, it goes to the left. So birth control pills are going to be much more powerful than metformin for control of androgens. And if we look at the metabolic aspects, however, the right now becomes more prominent. So metformin is much more valuable for control of metabolic associated problems in PCOS. So there's a role for each of them. And then finally, there's a combination of birth control pills and anti-androgen therapy, again, off-label, that indicates that anti-androgens are best used in combination with effective contraception, and they can be used in women if there's a suboptimal response to androgens. They can be pretty powerful to suppress new hair growth, and again, quite distressing for some individuals. So in summary, we didn't cover every area, but those are the main areas that we see every day in practice. But PCOS is the most common endocrine disorder in reproduction. It impacts at least 10% of reproductive aged women. It's a complex disease that has both genetic and environmental impacts, as well as antenatal contributions to its pathophysiology. And it's underpinned by insulin resistance, neuroendocrine disruption, and ovarian abnormalities. In addition to the reproductive disruption, there are lifelong metabolic risks in PCOS that we cannot ignore and must follow carefully. We believe it's an independent risk factor for cardiovascular disease and diabetes. There is currently no single medication that's approved for management of PCOS. The treatment we direct is at underlying concerns such as menstrual irregularity, infertility, androgen excess, and glucose intolerance, the main things that we're seeing in the younger women. As the etiology is further defined in PCOS, we are hopeful there will be development of targeted therapies that will be able to mitigate this symptoms that women have more broadly and reduce the overall long-term lifetime risk. So with that, I will close and be happy to take any questions. And I really thank you for your attention and again for the invitation.
Thank you, Dr. Hoger. That was wonderful. And we do have a lot of questions that have been coming in and continue to come in, so folks can submit their questions into the Q&A pod. Our first question for you, Dr. Hoger, how do you approach these assessments and preventative plan in women with lean PCOS, meaning they are not overweight or pre-diabetic or have high blood pressure?
Yeah. So generally in those individuals, again, you're making the diagnosis based on not their body type, but their irregular cycles, androgen excess, presumably. So whatever their symptoms are, you're going to address that. So I still have a discussion about lifestyle with thin women, because when we study those, and there's a number of studies out of Sweden and the UK that look at body fat distribution, and even in these individuals that are lean, they have some abnormal fat depositions, and they're certainly certainly at risk. Should they have an injury and become sedentary, their weight can increase quite rapidly. So we do talk about lifestyle, but we don't focus our efforts on that so much as we really direct to either birth control pills, if that's appropriate, or anti-androgen therapy. There's some evidence in thin women that metformin can still play a role in psychoregulation, at least based on the data, but it's not usually my first line therapy if there's no metabolic disease.
Great, thank you. The next question, is it possible to reduce the risk of developing PCOS if someone is diagnosed with PCOS and is able to make lifestyle changes like losing weight? Is it possible to reverse the symptoms or risk of PCOS?
Yeah, that is the excellent question. And the data don't support entirely that weight loss alone will erase PCOS, but it does definitely improve the symptoms of PCOS. There are a number of bariatric surgery studies where there's dramatic weight loss and you see the symptoms of PCOS pretty much reversing, but they're still there. If you look at ovaries, if you look at their response to ovulation therapy, they still have problems. So there's some still fundamental issues you're not correcting with weight loss. As far as prevention, that is really key. We do not have any way right now to know what is preventive for PCOS. Preventing weight gain, we all sort of believe. And when we look at the data out of Spain, where they have a very specific adolescent population, they've been using metformin for prevention. I don't think that's universally accepted, but it does seem to be that controlling insulin resistance early on in life does seem to help the symptoms from progressing.
Thank you. Our next question from the audience, what is the impact of PCOS on fertility/ovulation induction? Can you have a healthy pregnancy with PCOS?
Yeah, that's great. We didn't have a chance to talk about pregnancy, and that's an important question. So ovulation induction, this is something that obviously this is my bread and butter kind of work that I do clinically. It is very successful in PCOS. So there are two agents that have been tried, one off-label, one on-label. Clomiphene citrate is approved for this indication. Letrozole is actually a better drug. There's quite a bit of data, and the guidelines will recommend letrozole letrozole as the main drug that you would use in PCOS. But as far as a healthy pregnancy, there is significant risk. We know of gestational diabetes in pregnancy. We know there's increased risk of pregnancy loss, potentially preeclampsia. And so careful monitoring of the pregnancy, as I indicated earlier, you want to know ahead of time if someone has glucose intolerance prior to becoming pregnant. There's a very large trial out of the Scandinavian countries, Norway, that looked at providing metformin during pregnancy. It did not show a benefit to prevent these complications, unfortunately, although it had slight reduction in miscarriage. It wasn't sustainable as a recommendation in the guidelines.
Thank you. Our next question, is there any correlation with PCOS and premenstrual dysphoric disorder and thyroid dysfunction?
Okay, both very good questions. Partly, it's a challenge to answer the first part of that question, the PMDD, because most women with PCOS are, that you have to be in the luteal phase for that to be a formal diagnosis. And since most of them are not ovulating regularly, it's not something you can make a diagnosis of easily in the condition. And it's not felt to be higher. I think what we sort of misinterpret a little bit is that with hormone dysfunction and irregular cycles, there's all kinds of psychological impacts of not having regular cycles. So it's not specific to the luteal phase the way PMDD is, but it is very much a part of that irregular cycle. So there is some dysfunction associated with the irregular cycles, but not in the same manner as PMDD. With respect to thyroid disease, there is quite a bit of evidence now that women with PCOS have higher rates of thyroid disease, and it's not entirely clear why, but it is part of the diagnostic evaluation when we're doing for irregular cycles as well. So we're able to pick that up pretty quickly, I would say.
Thank you. Do I need to worry about menopause and additional symptoms of PCOS to evolve from menopause?
Yeah, another great question, and one we have almost no information about. We are gathering more. I mean, what we know, what we have so far in the data suggests that menopause does seem to occur a little bit later in women with PCOS. We're not entirely clear why, but it may have to do with the follicle pool that seems to be higher. So it's probably a year or two later than the average without PCOS. What we also see is there is a surge of androgen hormones in most women with PCOS without PCOS, at menopause, and that is not abated in PCOS. So you do see a slight worsening of androgen, but that you sort of become like the normal population. So what we actually see is this reversal, whereas women with PCOS, as they get closer to menopause, their periods get more regular. As women without PCOS get close to menopause, their periods get more irregular. So you're sort of having this role reversal. And so it kind of balances out when we look at the population data. We don't see abnormalities because everybody's kind of washing each other out. But we do know that, insulin resistance may get a little bit worse with menopause, and that's certainly something to be considered. But in reality, we don't have a lot of data post-menopause in women with PCOS because they stop basically going to their endocrinologist or gynecologist because they're not having periods anymore. So we do need more information on that.
Well, to follow that up, we've got a related question. If you have your ovaries removed, will this help with PCOS?
So yes, that's a great question. I probably get that question quite a bit. People who are very frustrated. I would say you are going to correct one problem. Your androgen levels will fall very dramatically, but you will not affect the insulin resistance and the dysmetabolic aspects of PCOS, and you're probably going to make your cardiovascular disease worse. So we do not recommend ovarian removal for women with PCOS.
Thank you. Okay, our next question. Is there any association between PCOS and preterm deliveries?
Yes. So I mentioned it briefly, but kind of flew over that in the end. So preterm delivery is higher in women with PCOS. It is, again, not clear why. Some of that may relate to body weight. We do see a higher rate in obesity in general, but women with PCOS do have higher stillbirth and preterm delivery rates that have been shown in several studies. But most women, to be assured, most people, that is not the case. I mean, most people have very healthy pregnancies, and the better we are going into pregnancy, the healthier we are in terms of managing our glucose abnormalities and our weight, the more likely we are to have a healthy pregnancy.
Great. Are you concerned about prescribing estrogen-containing birth control for PCOS patients since they might be at risk for hypertension?
So yes, with anybody who has hypertensive disease, we don't want to use birth control pills. But if they don't have hypertensive disease, we do not see a worsening of that condition developing with the use of birth control pills. And that's been studied in a lot of long-term studies. So we're always combining everything with lifestyle change, and treated hypertension is still it's not a contraindication to using birth control pills, but it's absolutely a great thing to pay attention to. And we do monitor when we're treating people with birth control pills, but it is a very powerful drug, and it does have such good effects in people who don't have hypertension that we don't worry about inducing hypertension.
Great. At what point in the menstrual cycle do you recommend checking AMH?
Yeah, so the highest levels are seen in the early follicular phase, so in the first few days of the menstrual cycle. So typically in our practice, if we have a normally cycling person, that's when we would measure it because we want to see the maximum amount. With PCOS, it really probably doesn't matter because they don't cycle normally. So then it's just more of a random.
Thank you. And then I think this will be our last question. Where do you think research for PCOS is most needed?
Oh boy, that's a big question to answer at the last one. So, I mean, I think obviously from the standpoint of understanding the pathophysiology at the basic level is still very needed. So we need funding for that because that's where our drug development is going to come from. With PCOS, obviously, we still have a lot of work in the genetics aspect of it because we don't understand its fundamental etiologies. I think looking at it in its origins in the antenatal area as well, because we have quite a bit of data coming out that this is a disease that probably is intergenerational. So we need to sort of understand that a little bit better in terms of prevention. But so the basic sciences need to be funded for PCOS so that we can have a pathway that we might be able to address with medications.
Well, wonderful. Thank you so much, Dr. Hoger. We can't thank you enough for this wonderful presentation and for answering all of our questions. This was so informative. And we want to thank our audience for joining us today. Just a bit of housekeeping, the CE code and claiming instructions will be emailed to all registered participants, and the recording will be shared in the next 2 weeks. Just a reminder that this is National Women's Health Week. You can follow FDA's Office of Women's Health on social media and on our YouTube channel this week and throughout the year for information and resources to promote the health of women. Again, thank you, Dr. Hoger. Thank you all for joining us today. And this concludes today's presentation. Goodbye.
Bye-bye. Thank you so much. I really enjoyed it.
Thank you.